sound check for those remotely connected. Brian, can you hear me?
Yes, Deb, loud and clear.
Thank you very much. Thank you.
You ready? Yeah. Directors, you ready? Yes. I'd like to call the meeting of the board to order. Will the secretary please call the roll?
Director Bott?
Present.
Director Garza?
Present.
Director Green? Present. Director Harrington?
Present.
Director Kim? Present. Vice Chair Lowry?
Present.
Director Ryder?
Present. Writer's here.
Thank you. Director Robinson?
Present.
Director Sorrell is absent but on the way. Director Webster Cross?
Present.
And Chair Taylor.
Present.
You have a quorum.
Thank you. The next regular meeting of the board is scheduled to be held on Friday, June 27th at 9 a.m. To begin, I'd like to entertain a motion to allow directors Ryder and Webster Cross to remotely participate in this meeting as voting members. So moved.
Second.
Thank you. The motion has, I'm not sure they want you to participate. The motion has been made and seconded. Is there any discussion on the motion? All in favor? Aye. All opposed? Thank you. The ayes have it, the motion carries. I would also like to acknowledge that Director Tanya Sorrell is present. Thank you. The first item on today's agenda is employee recognition, which will be reviewed by Dr. Michaelis. Dr. Michaelis?
Thank you, Chair Taylor. Good morning, directors. Good morning.
Morning. We're late today.
Waiting on the slide. There you go. I know we have a lot to get through, lots to celebrate today. So I will start off of the pages while we wait for this. Oh, there we go. Okay. Okay, so as always, we'll start with our new hires. We'll begin with Daniel McCormick, our Executive Chief Clinical Officer, Lauren Smith, our Chief Medical Officer, Ping Tang, Chair of the Division of Surgical Pathology, Clinical and Anatomical Services, Candace Mulder, Director of Clinical Research and Clinical Trials, Andrea Ramel, Director of Quality Improvement, Hospital-Based Services, Quality and Patient Safety, Kajal Jindal, Physical Therapy Manager, Pediatrics, Angela Tefera, Tuberculosis Clinic Nurse Manager, CCDPH, Latravia Johnson, Nurse Coordinator 2, Perioperative Nursing Providence, Delisha Holiday Chapman, Manager of Complex Care Coordination, County Care. Oops, let's go back one. We had one more name there.
Renee.
Darian Garola, Process Improvement Manager, Nursing Staffing, Float Pool. Thank you. And Devanshi Pandya Bangera, Executive Director of Nursing, Clinical Operations and Workforce Nursing Administration, Elena Fox, Director of Revenue Cycle Systems, Finance, Sandra Chavez, Clinical Nurse Leader, ACHN, Specialty Clinics, Rachel Bolonio, Nurse Coordinator 2, Medical Surgical Telemetry, Savitre Tubrung, HRIS Manager, Human Resources, Delisha Wormley, Manager of Finance, County Care, and Jason Lozechka, Manager of Inventory Control, Material Management. Congratulations as well to our team members who earned promotions since our last meeting. Kiran Joshi, Chief Operating Officer, CCDPH, Tarek El-Youssef, Chair of Division of Cardiology, Vesna Petronich-Rosic, Chair of the Division of Dermatology, Monica Mercan Almeida, Medical Director, Core and Ambulatory Services, Infectious Disease, Robert Needleman, Director of the Division of Adult Emergency Medicine, Stroger Hospital, Jessica Chapman, Director of Clinical Operations, County Care, Kate Hedlund, Director of Public Affairs, Cynthia Walsh, Director of Quality Improvement, Quality Assurance, Marie Jennifer Sears, Associate Program Director, Internal Medicine, Veronica Woodson, Senior Manager, Pre-Registration and Financial Clearance, Revenue Cycle, and Nessa Nkemji, Speech Language Pathology, Associate Manager, Speech Language and Hearing Services. And Arhani Villasenor Mustaine, Clinical Operations Nurse Supervisor, OBGYN, Lieutenant Gwendolyn Landfair, Hospital Security Officer 3, Security, Laura Turnan Hughes, Mental Health Director, CERMAC, and Jasmine Sanchez, Senior Project Manager, Strategic Planning and Implementation. Okay.
Well, congratulations.
Congratulations, everyone. Okay, and lots to get through here as well. And if the team members being recognized are with us, please stand so we can celebrate and recognize you. All right, so Cook County Health celebrated our ribbon cutting at the new Bronzeville Health Center, which will serve as an extension of CCH's historic Provident Hospital. The health center is offering family medicine, psychiatry, and rehabilitation services, including physical, occupational, and speech therapy. It's a 26,000 square foot facility projected to see 85,000 visits in its first year, and represents a $10 million investment by Cook County to improving access to care on the south side. Thank you and congratulations to everyone who participated. Just this week, on May 28th, the Office of Behavioral Health released its first regional strategic plan at a press conference with local leaders and community partners. The plan provides a roadmap to expand access to care, reduce behavioral health inequities, and provide culturally humble services by leveraging partnerships, resources, and strategic initiatives. Huge step forward. Congratulations, team.
Thank you.
We are also coming up on the award ceremony on June 26th for the 4th annual Providence Scholarship. Cook County Health, in partnership with Cook County government and the Cook County Health Foundation, launched our 4th year of the Providence Scholarship. The program awards future healthcare professionals with scholarships between $10,000 and $20,000. These scholarships support awardees who are from and dedicated to serving underrepresented communities in Cook County. We're very excited about that, and we hope all of you can come. We are excited and proud to announce that the dental clinic at our North Riverside Health Center is now open and accepting new patients. Congratulations to the entire team who participated in that project. Congrats as well to our Austin Health Center team for launching CCH's first methadone clinic. Methadone clinics provide medication-assisted treatment to those with opioid use disorder, and the program at our Austin location is a pilot meant to serve CCH patients seeking integrated primary care plus treatment of substance use disorders. Congratulations. John H. Stroger was named a Castle Connolly Top Hospital. Congratulations to our Stroger team. The hospital was awarded the prestigious distinction for its exceptional performance in mastectomy surgery and care, ranking among the best in the United States, in Illinois, and the Chicago metro area. Additionally, Stroger was named a top hospital in Illinois and the Chicago metro area for hernia surgeries. The hospital earned gold standard ratings for both surgical procedures at the state level. Congratulations. On April 15th, we hosted Congressman Raja Krishnamurthy, leaders from Protect Our Care, Illinois healthcare providers, advocates, and patients for a roundtable discussion on the importance of protecting Medicaid. It was really a great discussion. On April 23rd, CCH and NAMI Chicago held a press conference to recognize efforts to improve access to high-quality behavioral health support through NAMI Chicago's helpline and community-based peer support groups. CCH's Office of Behavioral Health is supporting the establishment of the helpline text-to-chat capabilities and the launch of public awareness campaign. The goal of the work is to reduce stigma and to help more residents take the first steps towards support. On May 8th, the Community Affairs team held the inaugural meeting of the Belmont-Cragen Center Community Advisory Council. The CACs are comprised of leaders from local organizations who provide insight on community health needs, identify opportunities for partnership, and help promote CCH services at the neighborhood level. This is our 9th Community Advisory Council, and the goal is to establish CACs for every community health center in CCH's portfolio. Welcome, Marceline. We had our recent Patient Safety and Experience Week. We have our poster fair winners here. I'm not going to read through them because the print is very tiny, but I see we have one of our poster fair winners here. It was really impressive to see. I'll just kind of talk about that with that. Sorry.
Thank you.
Yeah. Congratulations. It was really impressive to see this entire room was full of posters. It was really great. We also had the Institutional Research Day winners. Again, lots of posters in this event as well, and there's the winners. Anybody from that event? No. Okay. We awarded the Doctor of the Year award to Dr. Anwar Hussain for 2025. Dr. Hussain has worked in the emergency department at Provident Hospital since 2002. He's also chair of the hospital's emergency management committee at Provident, leading the multidisciplinary team for developing and implementing the hospital's emergency response plan. Dr. Hussain's colleagues describe him as caring and thoughtful and always willing to help a coworker. Congratulations, Dr. Hussain. Okay, congratulations to Dr. Rachel Rubin, Senior Medical Officer, Cook County Department of Public Health, for being celebrated by the Illinois Department of Public Health's 30 Days of Public Health. Dr. Rubin was recognized for her dedication to community health, public health leadership, and mentorship. And congratulations to Justin Miss, our Trauma Program Coordinator, for being recognized with the Clinical Excellence Award by the Society of Trauma Nurses. The purpose of the Clinical Excellence Award is to recognize an outstanding STN member whose contributions to trauma nursing fulfill the mission, vision, and core values of STN. Well done, Justin. Congrats as well to occupational therapist Haley Feller for being awarded the Cynthia Hughes Harris Fieldwork Educator Award from Rush University. The Cynthia Hughes Harris Fieldwork Educator Award is an award that honors leaders who demonstrate excellence in fieldwork education. Congratulations. Congratulations to Alex Normington, Chief Communications and Marketing Officer, for being recognized by PR News on their Top Women in PR list for 2025. The honorees include supportive, innovative, inspiring women making an impact on their organization. Congratulations, Alex. And congratulations to Dr. Florian Stroy for hosting an incredible two-day urologic education event at CCH. Things kicked off with a dynamic journal club featuring residents from top Chicago programs. Day 2 featured a hands-on surgical lab, providing residents invaluable practical experience in the growing field. Thank you to everyone who helped put this together and demonstrate CCH commitment to advancing education. Well done, Dr. Stroy. The Institute of Medicine Chicago and Cook County Health partner to host a maternal and child health symposium on April 22nd to unite industry leaders, community advocacy groups, and experts in maternal and child health across Chicagoland area to provide a comprehensive overview of the latest advancements in maternal and child health, emphasizing the intersection of physical and mental health. We also launched a new public health campaign aimed at increasing awareness of HIV prevention, testing, and services. The bilingual marketing campaign includes a combination of out-of-home advertising, digital media, and community engagement efforts. The first month, the campaign generated 12 million impressions and 9,000 clicks. Half of all visitors to the new HIV care website clicked to call the core warm line. The campaign's funded by a grant from Chicago Department of Public Health. Congratulations to our Cook County HIV Integrated Program and Communications team. Well done. Congrats as well to our CIRMAC Health Services team for being recognized by the National Commission on Correctional Health Care as part of their 2025 jail guidelines for the medical treatment of substance use disorder. Their work with the opioid treatment program at Cook County Jail was highlighted as one of the 5 case studies on MAT programs in action in the country. Excuse me. Congratulations, CIRMAC team. And congratulations to the Stroger team for getting a renewal of their emergency department approved for pediatrics, or EDAP status, within the Emergency Medical Services Region 11 in the state of Illinois. This recognition will be effective until 2028. Well done. And I think that concludes the celebration.
You want to take a breath?
Yeah, I'm gonna take a break.
Take a breath. Yeah. Well, like in all seriousness, I mean, we have so much to be proud of. Hats off to all of you. Like these are trying and turbulent times, as they say sometimes, right? And and it's easy to get stuck in the mire and in your head and in your soul, right? Quite frankly. But warnings like this and all of this, in all seriousness, inspire us, and we have a lot to be proud of. The work that we do is important, the work that you do is important, and know that it is appreciated and valued. Thank you.
I would just like to add, this is phenomenal, but I also want to shine a light on what's going on with the Providence Scholarship Fund. So including this year, we will have resourced our youth and the future of healthcare to the extent of $4 million. That is what makes this such a special system. Thank you.
The next item is public testimony. As a reminder, written testimony will not be read into the record, but will be included in the official record of this meeting and posted to the website. Madam Secretary, do we have any speakers who have registered to provide in-person or virtual oral testimony or submitted written testimony?
We do not receive
We
any,
do not.
no registrations, no written testimony.
Okay. The minutes of the April 4th board meeting are being presented for your approval. Are there any corrections or revisions that need to be made to the minutes? Hearing none, I'd like to entertain a motion to approve item 4A, the board meeting minutes of April 4th, 2025.
Second.
Thank you. The motion has been made and seconded. Is there any discussion on this motion? Hearing none. All in favor?
Aye.
Thank you. All opposed? The ayes have it. The motion carries. Next, Director Harrington will review the Audit and Compliance Committee meeting minutes.
Thank you, Chair Taylor. The Audit and Compliance Committee met on Friday, April 11th at 9 a.m. Our next regular meeting of the committee will be held on Friday, June 13th at 9 a.m. Nicole Emerald, Chief Corporate Compliance and Privacy Officer, reviewed the report, which included information on the following subjects. These projects included business associate agreements, notice of privacy practice, outside access agreements, education, year-end bench reporting review, and looking forward FY '25 priorities. Our action items include the following: County Care Compliance Plan and Fraud, Waste, and Abuse Plan, Internal Audit Strategic Plan, and the Internal Audit Charter. If there are no other questions on the minutes, they're being presented for the board's consideration. The minutes were included in your packet.
Any questions? Hearing none, I'd like to entertain a motion to approve item 4B, the minutes of the meeting of the Audit and Compliance Committee of April 11th, 2025, which include the approval of the following items: County Care Compliance Plan and Fraud, Waste, and Abuse Plan, Internal Audit Strategic Plan, and Internal Audit Charter.
So moved.
Second.
Thank you. The motion has been made and seconded. Is there any discussion on this motion? Hearing none, all in favor?
Aye.
All opposed? The ayes have it, the motion carries. Next, Vice Chair Lowry will review the Managed Care Committee meeting minutes.
Thank you, Chair. The Managed Care Committee met on April 11th, 2025. At the meeting, we received a report from Aaron Galena, Chief Administrative Officer for Health Plan Services, on the following subjects: health plan metrics, policy updates, member experience, outbound call center, text message vendor, health equity, housing, NCQA accreditations, health choice RFP. During the review of the information regarding county care disease prevalence by age, gender, and race and ethnicity, in addition to reflecting the percentage of membership, it was requested that future slides include the raw numbers of members. I also requested that the information regarding housing be shared with the Cook County Board of Commissioners to highlight the needs and services provided by county care. The next regular meeting of the Managed Care Committee will be held on Friday, July 18th at 10 a.m. If there are no further questions, the minutes are being presented for the board's consideration at this time.
Thank you. Do we have any questions? If not, I'd like to entertain a motion to approve item 4C, the minutes of the meeting of the Managed Care Committee of April 11th, 2025.
Make the motion. Second.
Thank you. The motion has been made and seconded. Is there any discussion on this motion? All in favor?
Aye.
Aye.
All opposed? The ayes have it, the motion carries. Thank you. Next, Director Garza will review the Human Resources Committee meeting minutes.
Thank you, Chairman. The Human Resources Committee met on Friday, May 16 at 10 a.m. The next regular meeting of the Human Resources Committee is scheduled for Friday, August 15th at 11:30 a.m. The committee approved one action item following discussion and review, and in closed meeting, the committee recommended approval of the proposed FY 2025 Executive Incentive Plan for the CCH Chief Executive Officer. The committee received the report from the Chief Human Resources Officer which is included within the minutes and included, information on the following subjects: FY 2025 metrics, FY 25 CCH HR activity report, current state of hiring separation, current state of nursing, hiring fair success, I should say successes, and current state of agency usage. The committee also received updates on strategic planning on the following subjects: nursing strategy, technology, CCH behavioral health services, which I'll just add my own editorial. I thought they were exceptionally presented, very impactful, insightful, and promising. So if you haven't had a chance to really dive into those, I would encourage. In order to avoid delays for the timeline and schedule for the strategic plan, the review of these strategic planning reports was delegated to this committee. There are no further questions. The minutes are being presented for consideration at this time.
Thank you. Any questions? Hearing none, I'd like to entertain a motion to approve item 4D, the minutes of the meeting of the Human Resources Committee of May 16, 2025, which includes the approval of the proposed fiscal year 2025 executive incentive plan for the CCH Chief Executive Officer. So moved.
Second.
Thank you. The motion has been made and seconded. Is there any discussion on this motion? All in favor?
Aye.
Thank you. The ayes have it. The motion carries. Next, Director Bott will review the April QPS committee meeting minutes. Director Bott?
Thank you, Chair Taylor, and I just want to say good morning and echo the kudos and appreciation for all the tremendous work that was shared earlier, because that all has an impact on quality and safety for the system, and really should be proud of all of that work. So thank you to the leadership and the team. Quality and Patient Safety Committee met on Monday, April 14th at 9 a.m. The committee approved the following action items, which are included in the minutes. Approved 2 Stroger Hospital Division Chair initial appointments and 3 Stroger Hospital Division Chair reappointments. Approved Stroger and Provident Hospital medical staff appointments, reappointments, and changes. The committee received the following reports, which are included in the minutes: 2025 Operational Excellence Dashboard Goals and Tactics, Provident Hospital Site Review, Stroger Hospital Site Review, ACHN Site Review, Regulatory and Accreditation Update, reports from the Chief Experience Officer, which included quarterly grievance report, patient experience survey data analysis, employee engagement, and wellness report. If there are no other questions on the minutes, they're being presented for the board's consideration at this time.
Do we have any questions? Thank you. If not, I'd like to entertain a motion to approve item 4E, the minutes of the meeting of the Quality and Patient Safety Committee of April 14th, 2025, which include approval of the following items: Stroger Hospital Division Chair, initial appointments and reappointments, and Stroger Hospital and Provident Hospital medical staff appointments, reappointments, and changes.
So moved.
Second.
Thank you. The motion has been made and seconded. Is there any discussion on the motion? Hearing none. All in favor? Aye. All opposed? The ayes have it. The motion carries. Director Bott will now review the May Quality Patient Safety Committee meeting minutes.
Thank you. The Quality and Patient Safety Committee met on Friday, May 16th at 9 a.m. The committee approved the following action items, which are included in the minutes. Approved Stroger and Provident Hospital medical staff appointments, reappointments, changes. The committee received the following reports, which are included in the minutes: update on Stroger Hospital leapfrog safety grade, 2025 Operational Excellence Dashboard Goals and Tactics, which include a Stroger Hospital site review, Provident Hospital site review, ACHN site review, regulatory and accreditation update as well. Next meeting of the committee is Friday, June 6th at 9 a.m. If there are no other questions on the minutes, they're being presented for the board's consideration at this time.
Thank you. Any questions? Hearing none, I'd like to entertain a motion to approve item 4F, the minutes of the meeting of the Quality and Patient Safety Committee of May 16th, 2025, which include approval of the proposed Stroger Hospital and Provident Hospital medical staff appointments, reappointments, and changes.
So moved.
Second. Thank you. The motion has been made and seconded. Is there any discussion on the motion? All in favor? Aye. All opposed? The ayes have it. The motion carries. Thank you. Next, Director Ryder, make sure your mic's on. We'll review the April Finance Committee meeting minutes. Director Ryder.
Coming to you from beautiful Springfield, Illinois.
Okay.
Thank you, Mr. Chairman. The Finance Committee meeting met on Thursday, April 3rd at 10 a.m. We're not planning to have the staff review the reports, but while you're reviewing the minutes, you'll see that a slide with a list of the contractual requests greater than $1 million will be up on the screen. The committee considered the following action items, which are included in the minutes. We conditionally approved 23 contracts and procurement items. Number 7 and 13 are pending review by contract compliance. We received and filed grant award related items, and we received and filed transfer of fund items. The committee received the following reports, which are also included in the minutes: the MBE WBE report of the February financials, a monthly report on the agency reduction plan, and Mr. Chairman, for this set of minutes, if there are no other questions, they're being presented for the board's approval.
Thank you. Any questions? I'd like to entertain a motion to approve item 4G, the April 3rd, 2025 Finance Committee meeting minutes, which contain the following action items: conditional approval of the contract and procurement items pending review by contract compliance, receiving and filing of grant award related items, and receiving and filing of transfer of funds. Thank you. The motion has been made and seconded. Is there any discussion on the motion? All in favor? Aye. All opposed? The ayes have it. The motion carries. Director Ryder will now review the May Finance Committee meeting minutes.
Again, thank you, Mr. Chairman. The Finance Committee met on Thursday, May 8th at 10 a.m. The next regular meeting of the committee will be held on Thursday, June 5th at 10 a.m. The committee considered the following action items, which are included in the minutes. We conditionally approved, as amended, 25 contracts procurement items. Numbers 2, 3, 5, 9, 21, 22, 23, and 26 are pending review by contract compliance. Again, on the screen, you'll see the contractual requests from the Finance Committee whose fiscal impacts are greater than $1 million, which are highlighted for your information. We also received and filed grant award related items. The committee received the following reports, which are also included in the minutes: a quarterly report of contracts executed under the CEO, a report of 2 emergency purchases, report of the March financials, and again, our monthly report on our agency reduction plan. If there are no other questions, these minutes are being presented for the board's approval at this time.
Thank you, Director Ryder. I'd like to entertain any questions. Okay. I'd like to entertain a motion to approve item 4H, the May 8th, 2025 Finance Committee meeting minutes, which contain the following action items: conditional approval of the contracts and procurement items, pending review by contract compliance, receiving and filing of grant award related items. So moved. Thank you. The motion has been made and seconded. Is there any discussion on the motion? Hearing none. All in favor? Aye. All opposed? The ayes have it. The motion carries. The next item is a proposed contract procurement item being presented directly to the board for consideration. Charles Jones, Chief Procurement Officer. Is Pam joining you? Just you. Okay. And Pam Casera, remote, will provide a review of this item.
Good morning.
Good morning.
Good morning.
Charles Jones, Chief Procurement Officer, Cook County Health. We have before you today one item for your approval and consideration. It has been, we do have a responsive letter from the Business Enterprise Development, formerly the Office of Contract Compliance. We have a responsive letter back. So, CFO.
Hey, Charles, can you get close to the microphone?
Yeah, please.
Oh, I'm sorry. Again, we have one item for you. It has been approved by the Department of Business Enterprise Development, which is formerly the Office of Contract Compliance. We do have a responsive letter back. Our CFO will present this item.
Thanks, Charles. Pam Casera, Chief Financial Officer. As Charles mentioned, this item before you is a request to extend and increase the contract with Guidehouse for $16,300,000. As you know, Guidehouse is an integral part of the revenue cycle um, process. They provide a variety of support services so that we can exceed our KPIs and have a successful financial viability with the health system. Happy to answer any questions.
Uh,
I don't have a question. It'd be interesting to see the return on that investment at some point.
RCM, yeah, yeah. I think we've had some updates in the improvement of metrics over time, with the work they're doing.
Yeah, thank you, Chair. We do present, Revenue Cycle presents about twice a year and includes this ROI on this contract and several others at that time.
Yeah, Director Ryder, I think this was in your last May meeting, is that correct?
we have not heard the Guidehouse contract, but I think we've been briefed on it previously. I do have a couple of questions, if I can, Mr. Chairman.
Please.
Yep. This is we have people who also do work in related positions. My understanding is we've been, as part of our overall view on agency reduction, we've had discussions around this. Can I get an update on where we're at in terms of where we're going, how much of this work will over time be transitioned in-house?
Sure, this is, oh. Did someone say something? This is Pam again. So again, this contract, only a portion of this contract is actually boots on the ground type folks. It's about a little less than half of this contract is for that function. We are still in talks to bring in some of that in-house over the course of the next 2 years.
Do we know how much we intend to bring in-house over the course of the next 2 years?
That has not been decided as of yet.
Eric, do you have an idea how many positions we're looking at phasing in?
So we have not yet landed on a final number, as far as I'm aware. I think
Okay.
The conversations are still ongoing.
All right, well, I think I'm very interested in knowing what that number is. I appreciate the work that we're doing under this, and I think the Guidehouse the work that Guidehouse is doing is important. But, as we've looked at, how we're insourcing our work, I know that this is part of that bigger picture of bringing stuff in-house. That's sort of an across the board type of mission. So if I can get an update on that at our next meeting, I'd like to at least know what our commitment is from the hospital side.
Yeah, we'll be sure to do that.
All right, thank you. Any other questions? Committee members? All right, hearing none, I'd like to entertain a motion to approve item request number 1 under 5A, the proposed contract procurement items. And you said this has been reviewed already?
Yes,
All right,
yeah, responsible letter.
Thank you very much. The motion sorry.
So moved.
Thank you.
Second.
Thank you. The motion has been made and seconded. Is there any discussion on this motion? Additional? All in favor? Aye. All opposed? Thank you. The ayes have it, the motion carries. Next, we'll have a report from the CEO, which will be reviewed, the CEO report, which will be reviewed by the CEO. All right, thank you.
So good morning again, directors. We are going to have Andrea Gibson come up and continue the cadence of our strategic plan updates. Excited to share with you this go around the first look at the draft strategies, so kind of the coming together of what we're hoping will be the final draft. And I believe next month on the timeline will be proposed final draft for all of these.
Good morning, everyone.
Good morning.
Andrew Gibson, Chief Strategy Officer. The first thing actually that is for your review is our monthly ARPA progress to date. So in your packet, I think there's the April update, which showed $65 million spent. Now the May update is almost $70 million. So we're continuing on a good cadence on spending that. We've got a couple issues we're working through. One, we're working to address a payment backlog to subrecipients, which is, a lot of requests for payments came in at the same time, and so there's been a backlog, and we're working to reduce that. We're also working through what some of the position budgeting will look like in 2026. So those are the two things that we're actively working on, but as we go through, we're hitting the right pace of $5 million a month. So that's the update there. Any questions on ARPA?
So we're 70% complete based on this.
Yeah, so, and ARPA does go through the end of 2026. As a reminder, this isn't just for this year. So the $5 million a month is to meet what our expectations were for this fiscal year.
Thank you.
Andrew, to that point, your last bullet, develop an updated sustainability plan post ARPA.
Yeah.
Is that going to be part of the strategic review of the strategic plan?
At a very high level, but we have some different sustainability plans, of course, is complicated by a lot of the environmental factors.
Correct.
I'll say. But includes the waiver that was granted to the state of Illinois that would allow payment for things like food as medicine and some housing for health programming. That is still the plan, and the state is planning to roll that out in 2026. So we would essentially be able to, bill for those services for Medicaid covered patients. In addition, there's some positions that are starting to generate revenue, in our social work positions in particular. And then, we have some other strategies that we're working through. So we'll probably come back to you at the same time as the budget on what we're thinking as kind of at this point in time, recommendation on sustainability.
All right, thank you.
All right. Okay, I didn't print this one. Do you mind making it slightly larger for me, Deb? Okay, this, in May, typically every month we look at what we've accomplished and what's coming soon. We've added a new sepsis alert and power plans for emergency department to improve our documentation. Under equity, County Care has a new text vendor who's already sent out 42 text campaigns to get people more engaged in care. CCH hosted the Community Health Workers Grant Sustainability Summit. I don't want to repeat things we had in the recognitions. We talked about the Maternal Child Health Symposium. The measles, the first case of measles was responded to by CCH. We've increased our approved external providers from 500 to 750. So that's a smaller scale credentialing process to allow referrals to our system. The employment plan amendments, as you're aware, those were approved that allow us to accelerate hiring for certain positions. Under optimization, we've moved Salesforce Health Cloud marketing to production to begin promoting CCH service capacity. And under growth, we've tested a proof of concept for new, or maybe I have the icons reversed. I think this is optimization. Tested the proof of concept for the new security service at Stroger and Provident EDs. We've improved our telecommunications via Verizon antenna upgrade to improve our cellular technology. We've improved our experience for patients by including broadcasting the channel lineup in our inpatient room. Things that are coming soon is, and we have a shout out here to Commissioner Lowry, hosting the National Alliance of Mental Illness Conference, Town Hall. The Regional Behavioral Health Plan was released at this point, so no longer coming soon. The Nursing Strategic Plan, the Power of Nursing newsletter is coming out that integrates the strategic plan into the nursing operations. Finally, cardiology and nuclear medicine are co-developing a service to offer weekend stress testing to reduce the length of stay for patients. And that is it. This is just me. Okay. All right.
Andrea, that was just a slide at the end of the CEO regular deck. I wasn't sure if I was supposed to reflect that because you've got the big deck for planning, so.
Sounds good. Okay. So on the strategic planning update, you see the familiar timeline in front of you. In May, as Director Garza already mentioned, we had some reports from Nursing, Behavioral Health, and Technology earlier this month. And today I'm going to go over draft strategic objectives. The goal is for the next board meeting to provide you with a draft strategic plan in the format of the official strategic plan, and then in July and August we would look to have a vote on that plan and incorporate the financial forecast, which would be timed with the budget information for the best forecast. And as a reminder, after that, it would go to the county board, where a vote would likely be in October after submitting it to the board in September, in hopes of having it in place for December 1 start. Next slide, please. So we had thought we would propose any change to the mission, vision, or values. But in discussion with the leadership team, one minor change is proposed for consideration. The mission had read establish universal access to the world's best care and health services, regardless of the ability to pay. And we're suggesting that it's to provide universal access to the world's best care. We're establishing sounds like we haven't done that at all, and we, provide that now, and we want to continue that for the next strategic plan. Next slide. We're also proposing streamlining the number of pillars. So essentially combining the patient experience and the quality pillar into one pillar. There's so much overlap there, and it seems to make more sense to our leadership team and allows us to communicate initiatives within that grouping a little more easily. Likewise, transformation and growth is the combined pillar of what had been called optimization, systemization, performance improvement, and growth, innovation, and transformation. Next slide. As a reminder, this is information that you've seen before, but it's summarized here to represent all of the different headwinds that we're facing as we think about the strategic plan. Certainly the dynamics in the market, the changes at the federal and state level, and the public health concerns that factor into the strategic plan. Next slide. So we have actually...
Excuse me.
Oh, sure.
And, thank you. Andrea, one of the questions on the proposed pillars, we have equity call as a separate pillar, but my question is that embedded within the other pillars as well? That you're having equity considerations in quality and workforce and transformation and in physical resilience. So
Well, I would say equity is part of everything that we do. It's really a fundamental part of our organization, and I do think it's part of every pillar to some extent. But we still wanted to call it out and elevate it as something that we think is very important. So it's not to create it separately, like, and we do equity, it's to really emphasize it. The strategic planning feedback. So we've gotten a lot of feedback from the community. We had a number of community town halls. We had 250 community members participate. We also had 160 community members provide survey responses and feedback on what our focus should be over the next 3 years. We met with county commissioners to receive feedback, as well as directors, but we've been doing that in this meeting and some briefings. The employee feedback, we had a variety of meetings that we participated in to obtain feedback on the strategic plan. We did receive over 600 survey responses, which is up from 30% during the last strategic plan. As you know, we had a number of board presentations that are listed here. We also had some good discussions during small group briefings that we have attempted to reflect in the strategic plan.
And your question, I mean, an increase of 30% in terms of survey respondents, that's a lot. So what do you attribute that to? Is it just that we're more open, we're providing great access? What do you attribute that to?
Well, you know, I think the last strategic plan was done during the height of the pandemic more, and I don't think, I think there was a lot going on. Not that there isn't today, but it was a different scale of what everyone was facing. I also think the leadership team did a really good job of pushing it out to their employees and trying to get them engaged in responding. So rather than just have an email communication go out, there was like backup to it, like, hey, reminder, this is an important thing. Next slide. We went over this 1 or 2 meetings ago on the SWOT analysis, and this really is a compilation of feedback from all of the community members who participated in either the surveys or the town halls, the employee feedback, your feedback, the leadership team feedback, as well, and commissioner feedback. So I won't read through it, but this helped build the foundation for what we ended up proposing in the strategic plan.
This list is not hierarchical. I mean, it's just a list.
It's just a list. I mean, I think commitment to mission is certainly hierarchical, but it's not intended to be read from most important to least important. No. Next slide. As we go into the pillar by pillar comparison, I wanted to take a moment and talk about some of the organizational differences and substantive differences to the prior strategic plan. We proposed a simplified pillar structure from 7 to 5. We've updated some of the language to be more inclusive of all departments in the organization, in particular county care and public health, so that it wasn't just from a provider perspective. We tried to focus on establishing high-level strategies before developing the specific tactics. In terms of substantive differences, I think, you know, we have a greater emphasis on access to care, value-based care, and population health, and increase the focus on CCH core functions, process improvements, leveraging benchmarks, things to, you know, that will allow us to make better use of the resources we have. Thirdly, we wanted to emphasize in this strategic plan enhanced support for patients or members in a redetermination process in maintaining insurance coverage. We did really well through county care, having a higher than state redetermination rate. We want to take some of that knowledge and apply it to our patients and members over the next 3 years. Ongoing contingency planning for resilience. That's something that we didn't have in the last strategic plan as much, where there was a little bit more of a focus on growth. And now it's more about like, how do we build resilience and continue to move the organization forward.
Have we identified or established metrics to measure all these things?
No. So what we're doing right now is establishing what the strategies are. The next phase will be what the tactics are, and then how do we measure them. Those will all be coming. All right. So let's go now. We're going to go through the 5 pillars and show you what we've distilled as the main strategies under each pillar. For the quality, safety, and experience pillar, we have 2 slides, and there are 5 overarching strategies that we have distilled from all of the discussion and feedback we've received. The first is, that we provide high quality healthcare and that we're a trusted messenger for clear evidence-based, equity-centered communication regarding individual and community health. The second one is that the patient and member care quality and safety outcomes exceed national and state benchmarks, that we continue to improve our quality metrics and ratings. Thirdly, that our overall patient satisfaction scores and county care member experience ratings increase. And on this page, finally, the CCH, that we achieve the AMCC Pathways to Excellence accreditation for nursing. The next slide shows the 5th item under this pillar, and this is where we really noticed that everyone wanted to focus on access. And so there's some more tactical things listed in the sub-bullets, but this really underscores that making sure people have access to care, that we improve it or maintain it in various areas. And you can see the various specifics in the bullets below. But this is kind of an expanded focus area within this proposed strategic plan.
Andrew, can I jump in for a second?
Yeah.
So we wanted to show kind of that next level of, we have system level strategies, and then we wanted to show the examples of kind of all of the things that pack into some of the bigger system level strategies. We were trying to be very intentional. I think those who were here, new in 2025, we really tried to deselect and focus on all of the system strategies. So this is an effort to kind of demonstrate, here's what, like, improved access. This is what this means across the organization through all of these additional tactics.
Thank you. Yeah.
Now shifting to workforce, we have 4 overarching strategies. The first, sorry.
Doing equity. Equity. Equity's next.
Oh, I stopped my clock. All right, equity. Missing. All right, so under the equity pillar, the focal areas that we identified include that CCH continues to foster a supportive environment that is welcoming and respectful of all, that health inequities are addressed through population health approaches, and this is where the value-based care contracting comes into play and helps support that overarching strategy. We're also looking to provide county care, or have county care achieve the NCQA health equity accreditation. Thank you, Deb. To advance sustainability by integrating environmentally responsible practices across our health system. So now I think we go to workforce, although I'm not sure. There, yeah. Under workforce, we have four major strategies. The first one is to make progress in hiring physicians and reducing the vacancy rate. The second one is to ensure that employee turnover remains low. We have a lower than national benchmark turnover, but based on the time to hire and a lot of factors, it's really essential that we keep it low, and we have a number of tactics identified there to support that. Next slide is the two remaining strategies under workforce include ensuring that there are opportunities available to the workforce for professional development and achieving additional competencies, and pathway programs, like we talked earlier about the Providence Scholarship Fund. I think it's more important than ever to expand these programs to ensure, future workforce in key areas. Next slide is transformation and growth, and we have a number of strategies under this pillar, including implementing performance and process improvement initiatives throughout the organization. This was present in the last strategic plan, but it's more important than ever that we maximize the use of the resources that we have. Secondly, aligning our productivity and operational metrics with national benchmarks. And that will also help us maximize our resources. Next slide. Continuing to cultivate our relationships with community stakeholders through CCDPH, through county care, through CCH as a provider. The next strategy is about the Office of Life Sciences to move to its next evolution now that we've been planning and beginning to build the foundation. We want to see in the next 3 years providing that this office provides a scalable structure to support the growth of research and sponsored programs. Next, we have focus on innovative and sustainable solutions to implement and improve healthcare delivery systems. That includes a focus on working on emerging technology, modernizing certain technology to improve our efficiency. Finally, we want to explore and elevate opportunities for coordination and collaboration between CCH as a provider, a health plan, and CCDPH. The last pillar is fiscal resilience, and we have two broad strategies. The one is maintain financial strength through a positive operating margin, and obviously there will be a lot of tactics under that, both on the revenue cycle side and the expenditure containment side, to continue that in this challenging time. The second overarching strategy under fiscal resilience is to support the financial health of patients and members. And this goes to what we talked about earlier in ensuring people stay insured as much as possible and working with them, with the financial counselors, with our redetermination team to ensure as many of our patients and members keep coverage during this tumultuous time. So that concludes my presentation. I think we have one more slide. This is just a reminder of where we are in the process, and be happy to take any additional questions or comments that you might have.
Yeah, I have a quick question about your equity slide. You mentioned that you're taking population health approach, and I didn't understand what you mean by that. And you mentioned that equity is built in all other pillars. So how would you actually ensure equity with your population health approach, which I just didn't understand?
Yeah, no, thanks for the question. Population health is, the way I think about it is really a focus on preventive, focus on preventive care. So you don't have downstream, more acute illnesses. And because that focuses on the population we serve and filling those gaps in healthcare, to make sure there's appropriate cancer screenings, appropriate upstream work that helps improve the population's health as a whole, so care doesn't languish and become more severe. So I think we tied it to equity because it really focuses on the population that we serve and improving overall health of the population.
And I think from an equitable standpoint, from a health equity standpoint, right, it's calling out those disparities that we see in health outcomes through different populations and trying to, improve those outcomes with the communities that we serve, and that cuts across the entire organization. It's working with CCDPH to ensure that we're, doing the really upstream, like not even yet healthcare things, engaging our communities, and then how are we improving access, how are we improving outcomes as a provider, and then how are we leveraging those outcomes through our health plan, right? So it's an entire engagement around how we improve outcomes for our community.
This is not a question, but an observation. Really what drives health is the tenor of a neighborhood and a community and the access to care. And so one of the things we don't often look at is economic development, which is a driver of health, particularly for those communities that are economically deprived or have low income. A lot of low income residents have historically not been developed. So it may be interesting to look at the intersect of economic opportunity and health as we move forward, because if we can improve those kinds of things, we can possibly reduce the wait time, reduce some other things, because we'll have a healthier population. It's long term, but it's something to look at.
Just building on Director Harrington's comment, I think there's things that Cook County Health already does that contributes to economic opportunity, and from jobs to other elements of investment in community, and it may be helpful on growth and transformation or another pillar that's appropriate to call that out. But the health gap and the wealth gap, certainly important that economic opportunity leads to health opportunity. And then connected to that also maybe to the access point, I don't know how county care is embedded within quality, safety, and experience in terms of county care quality metrics, or if that's within, growth and transformation, as you alluded to. But I suspect because it's, or I would say that because it's part of the system, should be considered within quality, safety, and experience as well.
Yeah, thank you. We'll have to make sure that it's clear. We intended for that to be embedded in there, so we'll make sure that that's very clear.
Yep. And then on equity, just to add to my earlier question, I think, the perspective of how it's represented visually and then explained may help, so folks may not misinterpret or interpret it differently than intended. And then defining it can also be helpful in this environment.
To not treat it as a afterthought, like to emphasize that it's correct.
Yeah, it's almost, I think what you're saying is that equity is the point, like, there's visually, this is it, and then it's a part of everything, right?
Yeah.
Versus the same. To be clear, Director Green, you had a question or comment?
So when you look at population health, prevention is part of population health. Prevention is part of population health. I'm wondering if there's the opportunity to outline and make clear that if we're doing prevention, we're doing primary prevention, secondary prevention, and tertiary prevention. That way, just the screenings aren't kind of the only thing focused on, but that allows people to have services that are accessible throughout the life cycle, any kind of chronic disease or illness. So primary, secondary, and tertiary.
Yeah, that makes sense to me to outline it that way. So thank you.
Yes.
Thank you.
Cardiologists came up with the concept of primordial prevention, the prevention of risk factors. And so there is a concept that looks at reducing the likelihood that people will develop risk factors moving forward. And that gets back to building healthier communities. So there's this connection, because we think about, what we really think about is managing disease. And what our healthcare system is about is managing disease. And if we can create healthier communities, back to the same thing, that we could possibly reduce the cost, reduce wait time, reduce a lot of the things we're talking about.
Agree. I think that's part of the strategy around how we, as a very unique organization with the Department of Public Health, with, you know, a health plan and being a provider, I think how those three things come together to really do exactly what you're suggesting. I think that's a real opportunity for us.
Director Sorrell.
Thank you, Director. And in regard to workforce, and I think this actually also kind of touches on what Director Ryder had mentioned earlier, and thanks for focusing on addressing agency and personnel and that swap. Did you have a benchmark that you were utilizing from the past strategy that's going to help you say how you can continue to incrementally increase that? Or what parameters are you utilizing when you do look at actually developing what's going to be the plan for the percentage of decrease, or how you look at whether this is working?
Yeah, I know that this year we have some goals, right? The percentage reduction goals. I think as you know, once we have the strategy approved, we would then work to define what's the right metric to evaluate against that. But you know, whether it's incremental based on what we've achieved this year, or if we move to just national standards for, or benchmark for vacancy rate, for example. I think the reason we didn't do that before is that we just had so many vacancies that built up during the pandemic that would have, we wanted something that would challenge us, but not defeat us, proud of it, be overwhelming.
Yeah, I think that's very important too, as we look at not only do we have attrition rates, but we also have now higher nearing retirement rates as well too. So that's going to make it really important to focus on how we can make sure we have significant workforce in-house versus agency.
I agree. I do. Our turnover has been better than a lot. It's been lower than a lot of, you know, like organizations, but I agree that it's still a burning platform for us.
Right. Particularly as our clinician, nursing, physicians, et cetera, all of us are aging. So making sure we're looking to make sure that we're continuing to have a good percentage in terms of agency staff.
Yeah.
Thank you.
Understood.
Sorry, one more question, Andrea. Again, and also want to just say, appreciate all the work that's gone into this with the team. It's really wonderful to see. On the transformation and growth slide, it's modernizing technology systems to improve patient care and operational efficiency. My assumption is you're considering AI and the kind of advanced technologies that are in play and emerging, both around ambient and, you know, supporting providers, but also around patient care, safety, experience. So, I mean, one thought is maybe simplifying this today, improve quality, safety, and experience, tying it back to one of your other pillars, but also maybe, you know, it was their thinking around these technologies that are, you know, going to continue to accelerate, and the strategy on how the system is going to leverage and engage in that to deliver on its mission.
Yeah. I think I originally had AI called out in here as AI, and the CIO asked me to change that to emerging technologies, because this plan will be, you know, over the next 3 years. And, you know, if you weren't here for the presentation that she made at the committee meeting, the HR meeting, right? I'd encourage you to take a look at it. She really outlined the technology strategies and some of the time that could be saved by utilizing these and allowing clinicians to focus on interacting with the patient rather than being behind a computer logging information. And I actually don't recall off the top of my head how many hours she said it would save, but it was significant. So I think that will help us, you know, do more with what we have, which is more important than ever.
Yeah, I also think, that we have to be thoughtful about how we consider this in the context of productivity. Seeing more patients isn't always necessarily the best, but saying, what can we do effectively improve quality, safety? Actually, this is actually a strategy to position for growth as well, to serve a broader population and to serve more people, but do it in a way that maintains, you know, satisfaction, meaning, joy for people in the system. So it's also both, you know, I think yes and to what you're saying, but also an opportunity to drive new services, to grow, to get better at what we do today. So it's also about predictive, getting in front, new opportunities, quality, safety, growth in what we could do, integrating public health, CIRMAC, ACHN, the acute system. So I think there's a broader play here that I think is incredibly important to the future of the system to think about.
One of the things that occurs to me, if we can reduce the time that people have to spend in front of a computer entering information, it increases the opportunity for physicians and providers and everybody to give more time to the patient and make us a more humane system. I think that's what's missing sometimes, because people look at the clock and they're thinking about what they need to do next. But if we can give people more time and they can spend that time actually building relationships, we'll have better outcomes.
And while it was initially kind of stated as more productivity, it was actually, that's where we landed during the HR discussion, was as we're putting our population health hat on, the patients who actually need, 30, 45 minutes instead of just the, 15 or 8.5 minute visit, they'll actually have the time to give that extra time, right? So it's not just packing in more patients, it's about having that time to really focus on outcomes.
Yeah, I agree. It occurred to me, I want to make sure every director's heard. Director Robinson and Director Garza. Yes, Director Robinson.
I guess there's quite a few things, but yes, most important. I guess I want to go where Director Bott went when we start looking at the emerging technologies. And I think that Director Bott made something that I had not heard anyone mention before. And I think I was present for the CIO's presentation, which I thought was very good. But the predictive analytics is a piece that I don't recall being mentioned, and that can become extremely important, especially if we say AI or machine learning, because when we start to look at and understand who has the potential, that can actually serve a great purpose of being able to do predictive or preventative care. And I think the devil is in the detail there, because we can come up with great plans, but being able to get the people to access and take advantage of it, that becomes extremely difficult. And I know that gets down into tactics. So I'm not trying to step down that far.
Yeah.
But in the strategy, I think it has to be included, because if we start looking at the idea of economics to help out and to change the population through that part, there becomes a lot of that piece that comes forward.
Yeah.
And if we miss that at this level, then we will never be able to execute it.
Yeah, I think that makes a lot of sense to add that. I do know we have piloted some predictive analytics, but I won't pretend I'm an expert on what we've done. I also like to get back to you on what we already do and get the CIO's input on anything that might be planned, but definitely include that in the language so it's not forgotten.
And it's good maybe to get Director Bott, because there are a lot of folks that will talk about predictive analytics, and they can throw a lot of things out there, and there are different tactics that can be used and some that can't be used that will get you very different results.
Yeah.
And I mean, there are a lot of people out there, a lot of smart folks that'll say they can do things, but they really cannot do them.
Mm-hmm.
So that becomes very crucial to understand that piece of the puzzle.
Thank you. And I think the tactical discussion will be ongoing. I just want to make sure that everyone understands, right? This isn't a, we're doing this and 3 years later we'll come back to talk to you about it again, right? This is this is gonna inform our board meetings and updates and, right, that tactical level of where are we at, what are we working on? So that catch-ball should continue that conversation, right?
The reason why I make the statement is because when you're coming up with the strategy at the beginning, if you don't pressure test it,
Absolutely.
then you'll come up with something that'll never happen.
I think one of the things we're hearing throughout, we just talked about this, is maybe it kind of took people down a rabbit hole. The idea of efficiency and improvement and leveraging emerging technology are not just the efficiency and improvement, right? It's about patient access, it's about patient care, it's about quality. I think that theme, like we were talking about, equity is embedded throughout. I think the other themes that an approach we encourage is to use the term resilience is also sustainability. Like oftentimes we do things that's not sustainable. So part of the strategy is, are we doing things that are sustainable over the long term? Improve the product, right? So much. Director Mark.
Yeah, just as a point of clarity, I think the savings are something to the extent of 7 or 8 FTE. So that's roughly about 16,000 hours. I would encourage you, Jay and Director, to take a look at that CIO presentation that we got in HR, because it's enlightening, and understand where the conversation went about, okay, now how do we invest that time? But efficiency and quality are synonymous. I mean, if you have one, it should drive the other, and I think that's the opportunity that you're speaking to, but I have confidence that the team is focused on that based on the presentations we got a few weeks ago.
Thank you. Director Ryder, any comments or questions?
Nope.
Ryder? Director Cross, do you have any questions or comments?
No, none. Thank you for the information.
Okay. So kind of thinking about the equity discussion, I'm gonna shop something here, and I'm sorry for the audible, but,
Andrew's like, no.
No, we've been
No, we're done. Let's
communicating
move on.
about it.
Since we are trying to be intentional about interweaving through all the pillars, and then it's also called out as a pillar, we have excellence in education as one of our values. Thoughts on taking that E and making that equity as one of our values, and then basically interspersing the things under equity in different places, except if you can go to the equity slide. So supportive environment and the NCQA accreditation, I might propose go to quality and experience. And then the pop health and sustainability through environmentally responsible practices go to transformation and growth.
It's clear, it's part of it, that equity becomes part of it, just
becomes a value, and it's
the value of who we are, it's embedded throughout. Then, to your point, not saying it's a separate thing outside, these things are a part of that, goes to the other area, but recognize there are others as well. The directors, you, make sense? Director Harrington, are you saying it doesn't make sense, or are you gonna?
No, it makes perfect sense, but what I think is important is to have a shared definition of health equity, because we throw these terms around a lot. So as you're planning, if it could be clear, if we had a definition that we can all look back to, that really drives what we're doing, as opposed to throwing around a term. And everybody has a different impression of what that term means, so everybody's looking for something different. So it would be helpful if we clearly define what we mean by health equity and what we hope to achieve. It's easier for us to reach some kind of agreement. That's a lot of times, that's the problem more than anything else.
Agreed, and equity in the workforce, and equity whatever, so part of it is defined. So I think that's.
Maybe we work on providing brief definitions of each value, right?
Yeah.
Innovation can mean different things, right? Respect. Yeah. How are we defining that as a value?
I have a question, and this is, the use of the word equity, are we now just placing a target on something that's unnecessary?
We've already had a target. It's part of our commitment. I get, I get your apprehension. I know what you're saying.
Just a question.
It's a question. I agree. I understand. I think we all, yeah, that's a question,
So I'm not saying not to do the work, I'm just simply saying,
to call it out.
unless there is a tactic to doing such, then which hand is it in? So that, I don't know.
You know, I like how Shannon says it. It's something we've done since we've come into existence, and you know, the current thinking is we're not going to shy away from it. It's what we've done for almost 200 years. So
Understood, and I'm not saying that. What I'm saying is, do you now limit the utilization of federal funds? Because now you place a target. Now, I'm asking a very real question.
No, you are.
yeah.
I just offer, first of all, it is a very real question, Dr. Robinson, Director Robinson. But we're seeing already a different narrative emerge from those institutions which are choosing to hold to their values, notwithstanding.
I hear you.
And I'll add, with this administration, we're already faced with the possibility of losing $900 million of support. So I don't think, no matter what we do, we're going to have an uphill battle with this administration. I think this is a time for us to hold steadfast to who we are, what we represent, and understand that this too shall pass. That's just my read of it.
And I will stand with you on that. I just asked a question. That's my
It's a great question.
No, I'm glad you asked the question, because we should have the open, upfront discussion about who we are and what we do, because I think I'm with, you know, not that we're gonna, I feel like Bob Ryder now, like.
Maybe you're channeling Bob right.
Time for a break.
It's not just what we say, right? It's what we do. And no matter what, we should say what we do. And we should be convicted in what we do. And we should be committed to what we do. And we are. So I'm comfortable with that.
Yeah, I want to provide a different kind of context. That my plan was to get here safely today. And anything could have happened along the way to change my plan. And so what we're talking about is a plan. We have to deal with the reality of the day-to-day. And so I think the process is good. It'll take care of itself. But we're dealing with some things now that no one would have expected before the presidential election. And things will change moving forward, and we're talking about a plan. So the plan needs to move forward, and we need to deal with things in real time. That's going to be the reality once the plan is complete. Whatever the reality is, we'll have to deal with it then.
We will. Yeah.
And certainly, stating it plainly makes it known that this is the commitment that we have, and we're not shirking from it, and not backing down before even being asked, as some are. So I think it certainly states where we are and stand as an organization.
So, I think, to the point about defining and saying what we mean and doing what we mean, I think will help in being proactive, and I agree with, Director Robinson, and the question of important to ask and discuss, but then how we strategically think about it. And the issues that I think we've talked about, from food to community to economic opportunity to all the other things we work on, there are things we can lift up as opportunities. I think about economic and social mobility, place and place-based work that we're doing, and then race and ethnicity and gender and all the demographic, socioeconomic issues. They all are sort of intertwined and layered together. And so equity is a value, and defining it important. I just would question, with Cook County Health being such an important educational institution, and what it represents and means and does for the future of health for our county, I don't want to lose that commitment and reflection, because it means a lot to the people that also train here. So how do we kind of balance that in our mission, vision, values is, I think, important.
You could keep education. I mean, we have 2 E's right now. Have equity and education.
Directors, thank you. Thank you very much for the constructive, very, very thoughtful and constructive engagement. As Andrew said, this is development, next plan is to say, these are
that concludes my presentation, I think, right?
Thank you.
Thank you. Thank you.
Good job, Andrew.
Thanks, Andrea. All right, that concludes the vote. Perfect. The next item is the quarterly report from the Cook County Department of Public Health, which will be reviewed by Dr. Karen Joseph, Chief Operating Officer, and Denise Gilbert, CCH, Chief Nursing Officer.
Thank you so much, directors. Thank you, Chair. So happy to be here this morning, and just wanted to acknowledge how much I appreciate the discussion about health equity that just happened. As both a leader in this organization and as a county doc, I really felt a lot of pride that we were having this conversation. So thank you all. So now I'm going to do what I do best, and I would argue what my profession does best, which is get out of the way and cede the floor to superstar Chief Nursing Officer Denise Gilbert.
That was good, Deb.
Well done.
Thank you, Dr. Joshi. Good morning, Director. I'm here to discuss the nursing program with Public Health and just to apprise you of the services that we provide, and basically what goes on in nursing within the Department of Public Health. So there are 7 programs that are under the purview of Public Health. The first one is our APORS High-Risk Infant Follow-Up Program. And this program is administered through the Illinois Department of Human Services. It is also a program that is going to sunset on June 30th. And we have applied for another program, Better Birth Outcomes, which I'll go into. But currently, this program, we receive delivery records that indicate to us infants that have high-risk indicators. Our nurses go out and they make home visits. They follow these infants until 2 years of age, making sure that they have received their immunizations. They give direction to the parents as far as referrals and so forth. And they provide case management overall. So we've been doing this program for many years, and as I said, it's going to sunset, but I'll get into that in a little bit. The next program that nursing administers, or in conjunction with our environmental department, is our lead program. And this program, we get alerts. The alert level was 5.0, but as of January, Illinois Department of Public Health decreased that alert level to 3.5. And let me just say that there is no level that is acceptable for lead in children. But at that 3.5 alert, when we receive that, our nurses go out, make a home visit. They do teaching and let the parents know what the possibility is if they do not get this lead level down, take the baby to the doctor. And the things that could come from that are, of course, developmental delays, problems with education. They go over the sources of lead, which in a lot of homes are chip paint, and the babies lick the paint. We do this in conjunction with our environmental department, and the lead risk assessors and the nurses go out together and assess the environment, and then the teaching plan is based upon that. They do continuous screenings, and they follow these children until the lead level comes down, right now below 3.5.
I'm sorry, may I interrupt and ask
Sure.
a question? Because ever since I've been on this board, this always bugs. This point right here just drives me bonkers, simply because this is not new, and it's been going on for so many decades. It's probably older than a lot of us in the room. Why can't we look at, I think the previous person who headed the organization said that you know the homes that have the problems. Would it not be beneficial to educate the folks in the home prior to having to get this level in their bloodstream, to let them to help them understand the impact of it? Because if we don't have the funding to remove the problem, then at least if we could let them know what the problem is, and then also let them know when this type of environmental issue occurs, chipping of the paint, then what are the resources that the individuals who live in those homes can do? Because this is almost like the dog chasing the tail, as opposed to stepping to our mission, which is supposed to be preventative population health care. There is a smarter way we could do this versus just waiting until the house is on fire and say the house is on fire. This is a genuine question.
Yeah, no, I think, if I may, I think you're absolutely correct. And in my mind, this is simply a question of resources, right? The resources that would be required to remediate every home, which is what would really
I didn't ask that, because I
No, no,
understand you don't have the money for it.
Yeah, but what I'm saying is that that is really what would be required
Yeah.
to reduce the lead levels to zero for all children, right? And that would require, sort of stripping the paint, changing out the windows, repainting, each of those homes, of which, you know, I would argue there are probably tens, if not hundreds of thousands of those homes in suburban Cook County. So, you know, we have a sense of what those resources could be. And, you know, I think we've had some conversations with CCH leadership as well as the president's office about increasing our staffing in the lead poisoning program, specifically to address the decrease in the lead level. But it's going to take time to do this work.
Right now, but just to make sure, because you said a lot there.
Yep.
My request wasn't to actually remove that issue, because I understand the funding is not there. My request is, can we educate the people who live in those homes about the conditions so that they could take the steps to ensure as much as possible that the children are doing those things that create the condition where we have 3 micrograms of lead in their bloodstream. So I'm just simply saying, let's have an educational campaign for the people who live in those homes.
I'm happy to think through what that approach could look like. I would say my concern is oftentimes these are rental properties. And so people are sort of going in and out. So it's not as if there's a sort of one-time kind of thing that would work. It would have to be an ongoing effort. But I'm happy to think through that.
So in terms of remediation, you're talking about homes at the individual level, lead paint, but how about lead pipes? And we hear a lot about like school, you know, lead pipe issues and things. So county or the state, do they have plans for replacing or something?
Yeah, so the most common causes of lead exposure in general are lead paint, you know, contaminated water, sometimes food, sometimes medicines. We've actually had instances where we had to talk to FDA to pull like a nutritional supplement from the shelves because a child was being lead poisoned by the medication, right? But in our jurisdiction, the primary source of the problem is lead paint, and so that's really been the focus of our work. Now, with respect to funding for replacing lead pipes, that's sort of federal level money. I believe the county does have some funding for that, but that's not a project that our agency has been taking the lead on.
Yeah, I'd like to provide some broader context for the work that you do. Having worked in public health at the city and the state level, what a lot of people don't realize is that we, as the Cook County Health Department, serve primarily suburban Cook County, not the city, but suburban Cook County from the public health standpoint. We're talking about somewhere between 2.3 million people, but the real factor is over 130 municipalities. So you have all these local jurisdictions that ultimately have some control over the housing in their area. And so it's a more complicated problem than people might think. With the city of Chicago, you have one health department, you have one department that does housing, and that's like 2.6 million people, but it's one entity that people can go to, and people know that. But the real challenge is working with 130 individual municipalities, some of which have small health departments, which consist of a nurse that does immunizations. So it's a bigger challenge than people might imagine moving forward. And I think we're doing the best we can. And as for education, although I haven't looked, I'm sure there's information on the Cook County Department of Public Health website about lead. So I'm sure we're pushing out that information, but our ability to actually mitigate the problem is probably limited because of the structures that we have to go through to get it done.
Thank you, Director.
I just want to add, I think the focus, at least in your presentation, is around dealing with or responding to, pregnant women or children that have already presented with,
That's correct.
with exposure to this. And that doesn't change what you're suggesting, Sam, because that still has to be dealt with. And, and I agree with what, Joe said, that, that's a lot of work to try to get into each municipality and try to have them be, hold landlords accountable for changing that environment that's resulting in this kind of exposure. So I don't know that that lands with this department, but I think it's an issue that has got to be raised in a different way, not necessarily out of here, but just in a way that really puts the focus on this issue and the environment in the way that you've talked about it historically. But I don't think that should take away from the work that, or the recognition of the work that you're doing to respond when it's a crisis for these families, when they present at the county.
Thanks, I appreciate that comment, and I also do want to acknowledge that prevention is critical, and I appreciate your comment as well.
And I would just build on the comments Director Garza just made, say thank you for the work that is done on this issue, and this is another example where technology and predictive analytics can help put the resources towards the best places that are needed, and can we do the education role to get people tested earlier that are at higher risk, right? Versus because those folks get tested later.
Yeah.
When I was at the Chicago Department of Public Health, we've done a number of efforts around this, so happy to chat.
Thank you. Yeah, I think we are moving towards universal testing broadly, so the hope is we will catch more kids.
Speaking of prevention, you want to talk about TB prevention?
Yes.
Thank you.
So we do have a TB prevention and control program where we screen for high-risk TB clients. They are treated in 3 of our ambulatory care facilities in suburban Cook County. So we have a clinic in Arlington Heights, a clinic in North Riverside, and in Blue Island. And so those patients are seen there. And if they have active TB cases, we also have, as a part of that program, direct observation therapy, where we have LPNs that go out and actually make sure that the patients are taking their medication. And this is an evidence-based practice that shows that if you go out and you observe them, that they are more likely to adhere to the treatment, and which is very important the first 14 days after they start treatment. So we do have that, and we also have case management, and our nurses constantly contact these patients, make sure they're adhering to their medications, and during those times, we also try to address any social determinants of health that might be impeding them from taking their medication. Of course, if they have to stay home, how are they going to get groceries and things like that? So we try to case manage and do things from all levels with that. Next question. Oh, sorry. Okay, next slide. We have a breast and cervical cancer screening program. This is a statewide grant program for women who are 40 years of age and older. If they're uninsured or underinsured, this program allows them to receive mammograms and pap smears to test for cervical cancer as well as breast cancer. We have vendors that give us appointments so that our patients can be seen in a timely manner. Because it's a grant, we have to adhere to time frames as far as when they're followed up after the diagnosis and so forth. Right now, our metric is at 100%. And so what we try to do more of now is get this information out in the community, get the number out into the community. We've done, not a fair, but we've given information at JDTC. We've given information at CERMAC. And so, we're just trying to make sure that people are aware of this program and able to take advantage of it. We have a genetics newborn follow-up program. And so what that does basically is the nurses who go out and do case management, they also screen for genetic disorders. It's mostly informational because we do try to make sure that the parents have aligned the child with a primary care provider, and of course they would be doing some screening as well, but we give them information to look at. So as the baby grows, if they're hitting certain milestones, and if they are not, the possibility of what that could mean that may have to do with genetics. We also have a perinatal hepatitis B prevention program, and the goal, of course, is prevention of hepatitis B transmission from an infected mother to the infant, and we do this through identification of a hepatitis B surface antigen. So positive women and their infants get case management and follow-up. We do home visits, and we make sure that they are connected with care so that they receive the vaccine. We track that so that the baby gets the vaccine within 12 hours after birth, and we track to make sure that within the 12 months after birth that they have received all of the immunizations required. And we're doing a good job with that so far. And I'll go into later how we're concerned about that with this new program. We also have a vision and hearing screening program, which I am extremely proud of because this program was on a 2.5-year hiatus due to staffing. We got it back up and running in September of '24, and since that time, we've done over 4,000 screenings for preschool children for hearing and vision.
And where are those done?
In suburban Cook County in the daycares and preschool. We also, to that extent, we created a digital form so that the schools can apply online, and then we contact them and set up a date to go out and do the screening.
If I could, I'd like to get more information relative to the breast and cervical cancer screening program statewide. As you may know, I led us to the birthday health screening program, so I need to see, would like to see the scope of this program.
Absolutely.
Thank you.
One more question.
Yeah.
Yeah.
I'm gonna be quick. This is IBCCP?
Yes, it is.
Okay, and we're doing it in the juvenile?
No, not in juvenile. I misspoke when I said that,
Okay.
but CERMAC.
Okay, it's fine, you know,
So we were given information.
okay, got it, I'm gonna move, because I know we have to move.
Okay.
My question would be to add on to the IBCCP, when people come in for any screening, but certainly the cervical health screening, are there vaccines available at that time or a discussion about HPV vaccine?
There's always a discussion about the vaccines, but since we don't have clinics that provide it specifically, we do refer them and make sure that they receive that, yes. Yeah. Okay. Next slide. When I spoke earlier about the high-risk infant follow-up program that will be sunsetting in June 30th of this year, the program that we applied for, which is a grant-funded program as well, is the Better Birth Outcomes. And so we applied for that program. I thought we would have heard on Thursday, but we still have not heard yet whether or not we are the awarded recipient, but our hopes are high on that. So just to
I'm
get
sorry, you applied for it from who?
for the Better Birth Outcomes comprehensive grant. Yes.
From IDPH.
From IDPH. And in that, we also collaborated with Erie Family Health as well, so that we can reach in the northern part of the county as well. But the Better Birth Outcomes, it's a maternal child health program, and it's established through the Illinois Department of Human Services, and it's going to replace the high-risk infant follow-up program. There are two components of that program. There's navigation and there's comprehensive. We applied for the comprehensive component because that requires RNs to make assessments during either the first, whatever trimester you encounter the pregnant woman in, also in the postpartum period, and then to provide case management for the infant up to 6 months of age. The focus is on the assessment and care and coordination of what they call the dyad. The dyad consists of the mom and the baby, and then up to 6 months after birth. Of course, it's based on a vulnerability index, and the parents have to be within 200% of poverty level. One of the advantages of us collaborating with Erie Family Health is the fact that they do the vulnerability index to a certain extent as part of seeing all of their clients. So all of the clients who we would encounter with them would be eligible. The providers determine the number of visits that we're supposed to make, so this is a little bit more lenient. It is a volunteer program. It's not a program that they have to participate in, so we have to sell the advantages of it. We will utilize suburban ACHN clinics, which is another area that we collaborate with. So those 5 clinics that are located within suburban Cook County, they all have prenatal services. What this program allows us to do is to be in the prenatal space more than we have been, because with high-risk infant follow-up, we get the indications after the baby is born. So this will give us an opportunity to provide more teaching and resources to women while they're pregnant. We have a multidisciplinary team. We are going to involve our community outreach workers, so they'll be a part of our team as well. And we will continue to pursue partnerships with community healthcare facilities. As you know, there are multiple healthcare facilities within these over 127 municipalities. And the last box just indicates when we applied, which was May 5th. Next slide. As I mentioned, we were collaborating with Erie Family Health. We collaborate with ACHN within our own network, and that's key to the work that nursing does within Cook County overall, within the Department of Health. So our breast and cervical cancer program, we contract with community healthcare facility vendors. In addition to Cook County Health, which we can also provide some appointments for mammograms as well, and for patients to be seen in the gynecology clinic here if needed. And we use them for their lab, mammography, and screening exams. We receive referrals from the communicable disease unit, and so for women who are positive for perinatal hepatitis B, the nurses provide case management, and our communicable disease unit, of course, is within public health. Our TB team and nurse epidemiologists work with CD also. So again, that was kind of the layers of work that nursing does. We work side by side with our emergency preparedness unit in the provision of pop-up clinics for seasonal vaccine administration and community responses for disease outbreak units. So we have just completed at the end of March our pop-up clinics for flu and COVID vaccine, and I have a slide coming up for that that'll give you some more metrics on that. And then our communication unit plays an integral part in our website development, which I will also discuss going forward, and formatting our content, the dissemination of information on multiple social media platforms, which helps to inform our community members, and they assist us in the creation of brochures and palm cards. And then we participate with the preschools, as I discussed earlier, for hearing and screening and vision programs. So just to give an idea of how important it is that we collaborate with other entities within the community as well as the other units within public health. Next slide. And then the next slide. So this is regarding the data that informs us. We have a very robust epidemiology department that has indicators on our Atlas platform, and it allows us to focus our intentions on specific areas that may need a little bit more help than others, because within the entire Cook County, and especially in the North region, we do have more affluent areas that may not need as much guidance as the other areas. Next slide. So again, discussing the hearing and vision screening, like I said, it had taken a 2.5-year hiatus, but now these are the total numbers of children that were screened in the ages 3, 4, and 5 in kindergarten, and then the total that has been screened since September of 2024. Next slide. This just gives a very clear idea of the indicators that are on our Atlas and that our epidemiologist department keeps our metrics for. So we have very specific indications, maternal care, emergency room visits. This is one of the things that we talk to women about in getting a primary care provider or obstetrician in making sure that they're not seeking episodic care in the emergency room. Maternal and mortality rates, we have indicators for infants born with birth defects, pre-pregnancy obesity rates. These are all factors that that indicate problems that will probably crop up during the pregnancy. Our VBAC rate, which is vaginal delivery after someone has had a cesarean section, alcohol use during pregnancy, gestational hypertension, teenage births, our cesarean birth rate, and all of these indicators are available for anyone to access on our atlas. Next slide. And of course,
I'm sorry, so you have the data on these pregnant women?
We do, and we have the data for our specific areas individually. So you would find information for Harvey, you would find information for Dixmoor, Phoenix, and in those areas, what their numbers are based on the number of premature births, based on the number of women who enter prenatal care late. All of that information is available.
So if you have this, you can actually be able to locate those individuals to help reduce this big problem that we have, because that's one of the questions. Who are they? Where are they?
That is our aim, but also know that a lot of the information we get, while we know the problem exists, the information that we get is usually 2 to 3 years old by the time it's on there. But we know it doesn't make it any less of a problem, and it does let us know what area to focus on. Now that we hopefully will get this Better Birth Outcomes grant, we will know what areas as well to focus our attention on. So that will help to guide us, absolutely.
Let me ask a question. If we have this in retrospect, could we not do predictive modeling to actually know what's coming because it would be in the area?
I think there's different components. We should just, I'm happy to talk offline in committee.
Okay.
Yeah, but there's different ways to approach it.
Okay.
Okay. So to that extent, of course, the big discussion is maternal mortality rate. And what this shows is the number of maternal deaths per 100,000 live births by ethnicity. And as you can see, non-Hispanic Black, that population is 38.94%, which is often 3 times higher than that of Caucasian women. So this is just giving you an indication by race for suburban overall. And then those that have not had prenatal care, of course, that adds to what happens with the infants when they're born, and it adds to issues as far as the mom, especially when we're looking at morbidity and mortality. And if you've not had care, if you've not had the education, of course, that puts you at a higher risk. So that's what this slide indicates here.
Yeah,
And
I understand that that's regardless of income.
yes, it's regardless.
That's important to keep in mind. So regardless of income, the rates are higher. So that means there's something historic going on.
Yes.
Yeah, and I would
Yes.
just add on that and make the implicit here explicit in that it's not about race, it's about racism, and it's about structural racism.
Next slide. No, I did. Next. Yeah. No problem. What this indicates here and what we looked at is, of course, pregnancy-related deaths. They increased by 40% in Illinois from 2015 to 2017, and then from 2018 to 2020. There are about 88 women who die each year while pregnant or within a year of pregnancy. And I'd like to say kudos to Illinois, because we were one of the first ones to extend care to 1 year for Medicaid for 1 year after birth, as opposed to the 6 weeks after birth. Black women have the highest risk of pregnancy-related deaths, 2 to 3 times higher. And then high poverty counties had higher rates of pregnancy-related deaths than low poverty counties. And of course, that addresses all of the social determinants of health, where there's no transportation, there are food deserts, and also lack of entities for them to be able to go to. Our next slide, after that one, next one. So, one of our answers to this, was the creation, my nursing staff and I created a micro website called everymother.everychild.org. And what this website does is address, at every stage of pregnancy, even prior to pregnancy, and it gives evidence-based information. It provides guidance. There are videos, and we have information, like I said, before pregnancy, during pregnancy, after pregnancy. We have a special section for LGBTQIA+ individuals that are now, the prevalence is increasing when they present and are different gender facing than what is expected, and the problems that ensue after that. We have resources that are listed specifically, and we have fact sheets that are downloadable in 5 different languages. So people can not only get that information, next slide, but then can download that information. They are able to have it as a resource, take it to their provider, be able to have guidance on what questions to ask. We're looking to make sure, we have someone, a maternal child health program coordinator, who we just brought on board, who will check the links and make sure that the information that's on there is correct. We're looking to make it more interactive and possibly include a chat bot so that when people are looking for something, they can find it immediately. And the languages that we have are English, Spanish, Polish, Arabic, and Simplified Chinese. Oh, I'm
Hey,
sorry.
thank you for doing this. I know I don't want to be rude, I have to go, but just to underscore the work, the importance of this work, you mentioned the difference in maternal mortality for Black women. You put 2 to 3 times, just to underscore it. During the time when these generations were enslaved, the maternal mortality rate was 1.6. It's actually higher now than it was when these populations were enslaved. So thank you for shedding a light on this and doing this work.
Thank you. And as part of a collaborative effort, we're also, we're thankful to Commissioner Miller, who added a $1 million amendment for doula services. So once that is up and running, we'll find a way to integrate that into the information that we give our patients as well. Next slide. So what nurses are also responsible for is mobilization during disease outbreaks. When we just had the measles outbreak, as a part of overall public health activation of our incident command system, we work collaboratively with our communicable disease department, our emergency preparedness unit, our community engagement teams, in making sure that the community is apprised of what's going on, doing tracking and tracing of individuals who might have been exposed and doing outreach to them. And then the nurses, in one instance, have gone out to the apartment dwelling where these people resided and made sure that they had their immunization, as well as pregnancy tests for women who would be at higher risk as well. So nursing does that. Next slide. So also nursing was an integral part in the pop-up seasonal vaccine clinics, and this indicates the numbers for each of the clinics where we had rotating Saturdays, these clinics, for flu and COVID vaccine. We gave a total of 1,783 vaccines. So, and that was totally free of charge. All you had to do was show up and have some ID and request which vaccine that you wanted. We worked collaboratively with County Care, which was wonderful. This was actually our 2nd year, and they were at each clinic event and provided redetermination information and eligibility for people to sign up. At some point, they were given a gift card for receiving the vaccine, so that was an incentive that was helpful as well. But County Care has been an active partner with us. And then, next slide. So lastly, just to, it's also another example of our collaboration with our policy unit. And there are, a plethora of bills and things that we watch, but these related to maternal child health, the expansion of the Medicaid provider base to include doulas and lactation consultants and home visiting nurses, where they would be able to bill for that. We support the Healthy School Meals, which is an appropriation that would implement school meals for all participating school districts, a free lunch to all students regardless of their economic status. And we also support efforts to increase funding for early intervention. This is needed, especially with children who have high-risk factors. And we know that about 4% receive services, although research indicates that 13% are eligible. And then finally, cannabis and mandatory DCFS referrals. We're currently researching this policy. Our nurses come in contact with this all the time. Of course, cannabis is legal, but then where do you draw the line? Because some babies are born with cannabis in their system. So, but DCFS may not necessarily be the place for all these babies to go. So we keep a watch on that. And that's just highlighting what nursing does within CCDPH. Are there any questions?
Yeah, I just want to commend you because a lot of this work is done outside the office and you're in people's homes. So you are actually touching lives in a very real sense. So I applaud you for that.
Thank you.
Director Sorrell.
Thank you very much for this report. Proud as a nurse to hear all of what nursing is doing. I do have a question with behavioral health and substance use being such an ongoing narrative, particularly with maternal outcomes. We know that's one of the highest reasons for maternal morbidity and mortality. Are there nursing interventions that have been part of the development in what you're doing? I didn't hear those as part of the.
Yeah, I didn't outline it specifically, but Public Health has a Here to Hear Me as part of that campaign overall, and so referrals are made for that. We don't have specifically nurses who do behavioral health, but they do make sure that they are referred.
Do you have a universal screening implemented for both behavioral health and then trauma as well too?
No, not automatically, not for trauma.
Because we know universal screening for behavioral health, substance use, the two questions, so has been a great indicator to be able to identify, if we're looking at early intervention, that's the best time to be able to do that along the.
Absolutely, and that will be a part of the Better Birth Outcomes.
Okay.
We begin to engage in that.
Great, and we'll certainly be rooting for us.
And we do the assessment when we come in contact with the mom and the baby. So for postpartum depression, we do that. That is a part of what we do now.
Okay.
I have a quick question about the health atlas. You have multiple indicators there. You mentioned there are 2-3 years of delay in terms of data. Do you have plans to actually improve the data return?
So that happens at the state level, where by the time they push the information out, it has taken them that long to validate, verify, scrub it, and then they push it out. It's not that we don't try to grab it sooner than that. It's not made public to us any earlier than they finish doing what they're doing with it.
That's unfortunate.
Yeah, it is. It is. But usually when they're on the radar, they stay on the radar, so we know that. Anything else?
Thank you.
Thank you.
Thank you, directors. Appreciate it.
Very much for the comprehensive overview. Next item is the Managed Care Committee meeting metrics, which will be reviewed by Erin Galena. Erin is there.
Good morning, directors.
Good morning.
Good morning.
First slide today shows our membership numbers. We are at 412,000 members. This is as of May. Looking forward to June. Well, first, this was a slight increase from the prior month, so we've seen some reversal in the prior trend where we were seeing some month-over-month decreases. Looking forward to June, we also are seeing an increase in membership of about 1,500 members as well. So The overall Medicaid market is continuing to shrink, but we've either shown decreases that's at a slower pace than the overall market, or now we're also seeing some increases. So overall, I think a sliver of good news here. The next slide shows some of these overall metrics, and apologies for the size of this. This is a new slide we've started to include. If you look at the top blue line there, that is showing our overall redetermination rate. So you can see that's been hovering around that 88 to 89% mark pretty consistently. The red bar is the percentage of individuals that when they come into Medicaid managed care and choose a health plan, what percentage of those individuals are choosing county care. So that is running at approximately 32 to 33% pretty consistently over the past year, which is great because that's roughly in alignment with our overall market share. So previously, if we looked back about 2 years, and this has been a key strategy for us is to try to increase these numbers. About 2 years ago, that was running at around 20% of individuals making a choice were choosing county care. So that's increased pretty substantially over the past couple of years.
And why do you think that is?
I think it's a combination of things. We've put in a lot of efforts across additional benefits into the plan, into our marketing campaign, and into trying to improve access and just the overall member experience, all of which are kind of direct strategies to try to improve those numbers. The next slide shows our overall market share. As I mentioned, we're sort of outgaining the market currently. As you can see, our market share has ticked up again. This data is from the state through March of 2025, so we're at about 34.9%. For context, a few years ago, we were around 32%, so we've been slowly but surely increasing that overall market share over the past couple of years as well. Blue Cross has also seen a little bit of gain in market share. They're now up to 28%, and it looks like some of that market share gain is coming at the expense of Meridian, Illini Care, and Molina. The next slide shows this trend that I mentioned. So on the right-hand side is the overall enrollment in Medicaid managed care. You can see that the market continues to decrease in terms of overall enrollment. Our membership is on the left-hand side, so we've had a slightly slower pace of that decrease. This is through March, so those past couple months of month-over-month enrollment increases aren't reflected here, but you'll see that as this data rolls forward. Next slide shows our membership compared to budget. You can see that May increase here, some of the reversal of that trend. Again, that'll increase again in June. We're continuing to perform well versus our budget assumptions. I will note, of course, that the healthy benefit for immigrant adults, the HVIA population, which is about 16,000 individuals, will lose coverage as of the end of June. So we will see a decrease in our membership of about 16,000 individuals at that time. So I think in terms just of our overall budget, I think we're still in a good position. We'll probably be running in the second half of the year right at those budget projections. But of course, a lot of challenges for that specific population as they're transitioning out of coverage. The next slide shows our operations metrics. All of these around our call center and claims and encounters acceptance rates are performing pretty consistently. No real concerns or call outs here at this point in time. The next slide shows our utilization per thousand. The red bars is prior period, the blue is current period. We've, I think, seen some stabilization here. We were expecting utilization to increase overall as we were coming out of the large wave of redetermination. So that is starting to kind of flow through in terms of the comparison point. So we're still seeing some moderate increase versus the prior period, but a lot more consistency, I would say, overall, both in our population and then now flowing through into our admission rates. And then our next slide Shows overall claims payments. So we're continuing to focus on that 30 to 60-day category. There has been some increase here. We do have some funding in terms of retroactive rate adjustments that we are awaiting from the state as they flush through the new calendar year 2025 rates. We expect that'll be in the range of 150 to 200 million of net rate adjustments that'll be coming to us, and at that point we'll be able to flow quite a bit of that funding down to providers and hopefully eliminate that 30 to 60-day category.
What about the 60 to 90, which seems to be have an uptick as well?
That 60 to 90-day category, you look here is just at that 200,000 level, and that's really just some variation in terms of some longer stay claims that sometimes flow through there.
I mean, I'm comparing to back 3 years ago, so
Yeah.
much better.
Yeah. And with that, I am happy to answer any questions.
Director, any questions?
Yes, I'd like to go to the overall membership. Question is, first of all, great compliment on the increase with the 32%. That leaves approximately around 60-something% that's going elsewhere, right? So the natural question I would ask is, where is it going? And let's see if we understand why.
Yeah, and your question's in reference to the overall market share capture. Yeah, I mean, I think we've done a good job of penetrating some additional market share. I do think there's likely some upper bound on how far that can realistically go. I don't think we've hit that point yet, but I think as we think about getting up potentially towards that 40% mark, I think it's hard to imagine, absent some other changes either in the market or in the number of MCOs that the state is contracting with, that we could potentially drive that much higher. So I think we would have to, at some point, start to look at growth through other avenues, such as other products or other opportunities beyond just this pure Medicaid market in Cook County.
Yeah. Okay. I mean, to the point, at one point we started thinking about the ROI on the marketing and all the things like that we're making, right? I mean, we've kind of become saturated. We're kind of know it's us and Blue Cross.
Yeah. And I think we're seeing
something different.
Yeah, and I think we're seeing that in the spend on marketing, right? Is that we've started to see a bit of a saturation on gain versus what we're spending to advertise.
Additional questions? Thoughts? Director Harrington?
Do we know the number of people that have Medicaid but don't have managed care? I mean, there's a population out there that I guess just has Medicaid and shows up at the ER.
Yes, that's correct. I don't know that number offhand. There's also some subpopulations on Medicaid that are not included in managed care. I think managed care covers roughly 85 to 90% of the total population in Medicaid. So there is still, a fair amount of number of individuals that aren't necessarily in a managed care entity. Part of that's timing. Individuals that maybe come into an ER and get signed up for Medicaid have some period of time before their transition to managed care. And then there are certain populations, for example, some individuals have to have a spend down requirement on their income before they qualify for Medicaid. And just because of some of those dynamics, they don't transition onto Medicaid managed care plans. And then there's also some certain highly specialized subpopulations that aren't included in managed care.
The number I saw a few months ago was about 600,000 to 700,000. I think including that group is duly involved in Medicare, Medicaid as well. And always signed MCOs, the state HFS underwrites that directly. Statewide, I should say, not county.
Thank you. Any additional questions? Hearing none. Aaron, thank you very much for the update. Thank you. Any additional comments? Thank you. The board will not be going into close. Any further questions from the board members or directors? Comments, thoughts? Okay. The board will not be going into closed session today, so if there are no further questions or matters to discuss, we can move to adjourn this meeting. which has been a very thorough, comprehensive meeting, I must say. Given that, I'd like to entertain a motion to adjourn.
So, second.
Thank you. The motion has been made and seconded. I don't think we have any discussion, but any discussion? All right, all in favor? Aye. All opposed? Thank you. The ayes have it, the motion carries. Meeting is adjourned. I was trying to be democratic. I wasn't.
I prefer trying.